Well, welcome. Members of the board, if you want to take a seat, I think we're going to get started. We just have quorum. We expect a few others to join us. Okay. Well, welcome to meeting 7 of the Board of Health. To members of the board and to members of the public, you can follow the agenda and the debate on your computer, your tablet, or your smartphone at toronto.ca/council. The board acknowledges the land we are meeting on is the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples, and is now home to many diverse First Nations, Inuit, and Métis peoples. We also acknowledge that Toronto is covered by Treaty 13 with the Mississaugas of the New Credit. Let me begin just with the formalities. Are there any declarations of interest under the Municipal Conflict of Interest Act? Seeing none, can I have a confirmation of the minutes from the 6th of May 2019, moved by Trustee Lapredi? All those in favor, opposed if any, that carries. And you have, we're now going to quickly go through the order paper. Item 7.1, we have a presentation and a deputant, so that will be held. Item 7.2, the Indigenous Overview Strategy, we will have a presentation from Michelle Sue, and those are going to be dealt with together, item 7.1 and 7.2. Item 7.3, FASD, activities to address key priorities. We have a deputation, so that will be held. Item 7.4, Student Nutrition Program, Services and Subsidies. We had deferred this because at our last meeting we didn't know if we had money this year. Apparently we now do again. Can I have somebody would anybody like to move the recommendations? Moved by Peter Wong. All those in favor? Opposed if any? Carried. That's item 7.4. Item 7.5. The Toronto Public Health operating budget variance for 12 months. We do not have any deputations on this. I would just like to note, though, that I will move the recommendations, but before that, on a budget of $255 million, we had a variance of a positive $51,000 surplus. That's 0.1%. That is budgeting as that is budgeting to perfection. And so to our staff on the finance side at Toronto Public Health, well done. And to folks at the province who think we don't know what we're doing, just read the report. So item 7.7, I will move those recommendations. All those in favor, opposed if any, carried. Item 7.8, Toronto Public Health capital budget variance for the first 4 months. Would anybody like to move the recommendations? Councillor Layton, all those in favor, opposed if any, carried. Item 7.9, we're going to have a presentation on that. So that takes us to the top. Maybe just before we dive right in, I just want to take a moment to, on behalf of the board, thank the Medical Officer of Health, Dr. Davila, and the exceptional team at Toronto Public Health. The last 2.5 months have been nothing short of exhausting for our staff. Emotionally exhausting due to the uncertainty of what was happening in the provincial context, and physically exhausting because they worked flat out to define and publicly articulate the value of the work we do and why we do it. And the net result, as you all are aware, is that the retroactive cuts have been reversed. We do not know what the future holds yet. I can advise members of the board that the Premier's office has told our mayor, both directly and in subsequent conversations with his office, that future cuts are on hold, subject to a full review with us. That is what they have said, and so we are going to hold them to their word, that this isn't a delay in a cut, but rather a reset. And so that is what our work now moves towards. But again, I want to commend and thank Dr. Davila and members of the Toronto Public Health staff for all their work, and please join me in giving them a round of applause. All right.
We have item 5. We don't have item
All right, and then I noticed that I omitted item 7.6, Toronto Public Health Capital Budget Variance for the first 12 months, moved by Trustee Donaldson. All those in favor, opposed if any, carried. And item 7.7, Toronto Public Health Operating Budget Variance for the first 4 months, moved by Trustee Donaldson. All those in favor, opposed if any, carried. All right. With that, we are going to go back to the formal agenda. We are going to deal with items 7.1 and 7.2 together, and so we're going to have a presentation first from the Medical Officer of Health, and then followed by Michelle Sue on the Indigenous strategy, and then we will move to deputations before taking it back to questions. Over to you, Dr. Deville.
Thank you, Mr. Chair, and thank you for the acknowledgement as well in your opening remarks. I would like to add to that as well my own personal thanks to the entire team at Toronto Public Health. It has been, I agree with you, a rather emotionally and physically challenging time, so I can't thank the team at Toronto Public Health enough. However, I think it's also worth it, while I have the microphone, to say thank you as well to our chair, who has been a tireless advocate on behalf of public health, not only for the city, but for the province. So if I may, while I have the microphone, I would ask you all please for a round of applause for our chair, who has been a true champion for public health. So with that, I'm going to call your attention, members of the Board of Health and those of you who are visiting us here today. We've got a presentation on 2 screens up here in front of you in respect of the Toronto Overdose Action Plan. It is a status report for 2019. It is that period of time. I think we're at a point where it is time to update you as members of the board. And I'd like to focus in particular on the key actions that we've taken over the past year. I will also provide an overview of a 2019 update to our Toronto Overdose Action Plan. It's attached to the staff report, which I believe you should all have in front of you. I would be remiss if I didn't tell you that we are bringing forward this report, and in particular, I'm bringing forward this report with very grave concerns around the situation in which we find ourselves. We continue to be in the midst of an opioid poisoning crisis. It continues here in Toronto. It continues elsewhere in Canada. And the crisis is indeed claiming thousands of lives. A recent Statistics Canada report, which was written up in the mass media, and you may have seen it yourself, found that life expectancy in Canada has actually stopped increasing. So I want you to just think about that for a brief moment. Life expectancy in our country has stopped increasing for the first time in 4 decades. And the reason why, a major reason why this is happening, is that young men and women throughout our country are dying at higher rates, and this is mostly attributed to opioid-related overdoses. This is the significance of the crisis that's in front of us. It continues on, and it's something that we must continue to be vigilant about. And I think you'll have heard me say this before, and you will probably hear me say it again. I do believe that this is the defining health crisis of our time. So by way of background, just to refresh everyone's memory, the Board of Health endorsed the Toronto Overdose Action Plan back in March of 2017. And as you'll likely recall, the plan does actually target actions towards each level of government. We at Toronto Public Health continue to work collaboratively with other divisions throughout the city, with other levels of government, with community and institutional partners in furtherance of this action plan and in furtherance of the targets that are set there. The multi-sectoral Toronto Drug Strategy Implementation Panel, which is chaired by Councillor Perks, provides strategic advice and oversight to our work on this front. And as you'll likely recall through the many interactions that we've had here at this board, the board has considered many items related to implementation of the action plan. And right now I'm going to provide you with some highlights of our collective work on this issue. So here, unfortunately, is the rather grim situation that's before us. In Toronto in 2018, there continue to be an alarmingly high number of deaths caused by opioid poisonings. For 2018, our preliminary data show that there were about 294 opioid overdose deaths. And this is still, again, while I realize we're into June of 2019, there are some data that continue to be confirmed by coroners. I would expect that this number will go up, but right now our preliminary data suggests that the total number of opioid overdose deaths for 2018 is just under 300. So we can see that the increase in deaths that has really been unprecedented in this city started in 2015 and continues on. Unfortunately, preliminary data for the province as well, unfortunately shows the same trend. In 2018 for Ontario, there were an estimated 1,363 opioid overdose deaths. And again, we expect that this number will continue to rise as the coroner's office continues and completes a number of investigations that are ongoing. Turning to the next slide, we also see the impact that the opioid overdose crisis has had in respect of our paramedics partners. And this graph actually shows you the monthly number of suspected opioid overdose calls received by Toronto Paramedics Services between August 2017 and March 2019. And as you can see, there continue to be a sustained and high number of calls over that period of time. And if you look towards the right side of the graph, you'll see that in fact there was a surge in calls in the first 3 months of 2019. During that time, our paramedics colleagues responded to over 1,000 non-fatal and 51 fatal suspected opioid overdose calls. Those are alarming numbers. Turning to 2018, we know that our paramedics colleagues responded to over 3,000 non-fatal calls and 146 fatal suspected opioid overdose calls. We also find that in general, paramedics tend to have to respond to a higher volume of calls in the summer months compared to the winter. And, it's our expectation that this summer will likely hold the same pattern as it has in the past. Turning to the next slide, we have a bit of a graphic representation of drug overdose in Toronto, and here you actually see the location of opioid overdose calls that are attended by Toronto Paramedic Services. These are data on the slide for 2018. It actually shows the locations where paramedics made contact with individuals, which may in fact be different from the location of the 911 caller. As you can see by this graph, or this pictorial representation, the highest concentration of calls were in the downtown area. However, as you can also see, opioid overdoses occur across our city. These patterns, I would say that the patterns in respect of the highest proportion of activity happening in the downtown core is fairly consistent, but we do see fluctuations over time in respect of these geographic patterns. Data from our supervised injection service at the Works shows a steady increase in demand, and that's depicted here in this graph, which shows the increase in visits since we opened our service in August of 2017. What's a little more challenging to see, and it's towards the bottom of this graph, are the little bars at the bottom which indicate the number of overdoses that were reversed at the Works, which have been increasing as well. I should let the members of the board know that since opening day, there have been over 50,000 client visits at the Works, and staff have treated about 845 overdoses. So let's reflect on that. These are unbelievable numbers. 50,000 visits at the Works since we opened, reversed almost 900 overdoses. In the first 4 months of 2019 alone, our staff responded at the Works to 253 overdoses. And I will remind you again that these numbers actually only represent the figures for one supervised consumption service in the city, right? Our site at the Works. It is the busiest such service in the city, but it is just one. So as I was alluding to there are other supervised consumption services and sites operating in Toronto, and in fact, there are 9 in total. And since that first service opened in 2017, collectively, these services have had over 106,000 client visits. Together, they have reversed almost 2,000 overdoses. And looking only at the first 4 months of 2019, they recorded just over 40,000 client visits and almost 850 overdoses reversed. These are very significant numbers. Turning now to the situation and that which has been happening at the provincial level, as you likely know and remember, the province has changed the funding program for supervised consumption services around our province. All 9 of the existing services, supervised consumption services in Toronto, applied under the new model put forth by the province called the Consumption and Treatment Services Program. And towards the end of March, the province announced the approval of 15 such consumption and treatment services across Ontario, including 6 in Toronto. 2 of the services that were operating here in the city were not approved as part of this program, and those are the services at Street Health and at St. Stephen's Community House. Fortunately, both programs continue to operate. They're operating, however, with short-term funding that they've managed to put together with the help of a variety of community partners. However, what is important is that in order for them to continue to operate, they need to find sources of sustainable and ongoing funding. With respect to the 9th of the 9 services, because again, only 6 were approved under the Consumption and Treatment Services program of the province, that 9th one is our service at Toronto Public Health, the Works. Our application continues to remain under consideration by the province. However, we do continue to receive provincial funding in the meantime. Turning now to the activities that are happening across other city divisions, there is a fair amount of activity and there is active participation in the overdose response from other city divisions. So I can tell you that the majority of shelters and 24-hour respite centers funded by our colleagues at Shelter Support and Housing Administration have staff on site that are trained to recognize and respond to overdoses, and they have naloxone on site as well. With respect to the activity that's happening in our Parks, Forestry and Recreation Division, all of our parks ambassadors are trained to administer naloxone, and they do carry it with them. And all of our Toronto Public Library branches and locations are stocked with overdose emergency kits that include naloxone. And it is mandatory for all staff at library branches to complete overdose training. So you can see that we're partnering. These are just some of the examples in which we're partnering with our other partners throughout the city divisions. Turning now to the subject of harm reduction services, we know that having more harm reduction workers is a critical component to our response to the overdose crisis. I can tell you that Toronto Public Health staff at the Works have expanded their outreach efforts and continue to do so to reach more people who are struggling as part of this crisis. We also continue to support community-based services to expand their overdose prevention efforts, including outreach, through a variety of activities, including the Toronto Urban Health Fund. Turning to the subject of treatment, we know that access to effective treatment is key and a critical component of addressing the overdose crisis. We know that the provincial government has committed, or they've stated their commitment for more resources for treatment. And last year, they actually signed an agreement with the federal government to this effect. However, what we don't know yet is how much of this new funding will actually flow here to Toronto. We know that there is an area of expansion that has been taken on provincially, and that has to do with the so-called RAM clinics, that's rapid access to addiction medicine, We now have 11 such clinics in Toronto, which provide quicker access to treatment. We are also actively working as Toronto Public Health staff with our health and community partners to try to get managed opioid programs implemented here in our city. This would certainly expand the range of treatment options that are available and help move people out of the toxic illicit drug market into a safer supply. I hope that you'll recall, as members of the board, that we brought a report here in February on this subject. However, we have yet to see provincial funding committed to these critical services. Turning now to the Toronto Indigenous Overdose Strategy. There was such a strategy that was developed for Indigenous peoples in our city. You'll recall that the board endorsed this strategy in February. Just at a very high level, I don't want to take, and not that I ever could, don't want to take any thunder from Michelle, who is here to present on this shortly, but I will tell you at a high level the recommendations in the strategy focus on prevention, on harm reduction, and treatment. And I would like to just say up front that we are committed as Toronto Public Health to working with our partners in the Indigenous communities here in our city to implement these actions. But you will hear about this in far greater detail and probably far more eloquently than I can provide to you from Michelle Sue, who is the principal consultant on this initiative, and she'll be giving us a presentation very shortly. So turning now to the subject of drug policy, we did host a community dialogue on a public health approach to drug policy last year. We worked with an expert advisory committee and with Ipsos Public Affairs to facilitate a community dialogue. And we heard from people throughout our city that our current approach to drugs in Canada is not working, and that drug use should be treated as a public health and a social issue, not a criminal issue. So I think I will leave it at that for that slide. I suspect we're going to continue to have these conversations. You'll be pleased to hear, Kate Mulligan just informed me that there is a meeting currently of the Association of Local Public Health Agencies. We as Toronto Public Health sponsored a resolution there in respect of decriminalizing drugs for personal use in Canada. That was approved, I understand, at the Association of Local Public Health Agencies annual general meeting just happening right now. So we're continuing to advance the discussion on that issue, and we'll continue to do so, I suspect, for quite some time. Now, as I mentioned before, the Toronto Overdose Action Plan was actually approved in March of 2017. It seemed like it was an appropriate time, 2 years in, to update the plan, and we wanted to check in with respect to our community stakeholders to ensure that the action plan continues to reflect current needs. We actually gathered input through an open online survey, and we actually held a number of consultation groups with people who use drugs. Very high-level summary, and the action plan and some of the summaries are all included in your board packages today. Just to give you a little sense as to what we got from those consultations, first and foremost, there was general agreement and general consensus amongst those who were included as part of the consultation that this continues to be an urgent issue, an urgent public health issue for this city. And clearly that more action is needed urgently by all levels of government. We are committed to undertaking the work that we have articulated is required in order to address this successfully. And again, you'll find far more by way of detail in the community consultation summary, which is attached to the staff report as part of your package. What we heard were there were key areas for action, and we are actually advancing that. You will see those in the recommendations in today's report. We need to actually provide more service and to better serve those who are frankly underserved in our community, whether we're talking about specific populations or geographic areas of our city. We need to advance in respect of managed opioid programs so that people are not forced into a situation where they're having to go to a very toxic drug supply in the illicit market. They need access to cleaner, safer options. And we know that there are challenges to many women in our city who would like to access treatment and treatment resources, but are unable to do so out of fear for losing access to their children. And we recognize that this is an important area, and we're committed to advancing work in this area as well. Other areas for action as described through the community consultation, or as obtained through the community consultation and as described in our report. We know that more efforts are needed to ensure overdose measures are available in housing settings. We know that one of the greatest risks is in using alone, so we know that we need more by way of overdose measures in social housing. We heard that the community wants Toronto Public Health to focus on public education and awareness about the opioid poisoning crisis. We know that people are interested in us continuing to advocate on decriminalization. We need to reduce the impacts of criminalizing drug use, and we need to reduce stigma. And I would suggest to you that the feedback overall complements what we've currently got in our overdose action plan, in the Toronto Indigenous overdose strategy, and provides us with a great deal of direction on the go-forward basis. So with that, I realize I've taken up quite a bit of your time. I hope that that provides you with a useful summary of that which is in the report and in the community consultation summary attached. I will turn it over now to Michelle Sue. She is here to provide a bit of a presentation to the board and those of you who are here in attendance as guests. She was hoping to actually provide this presentation back at our February board meeting. Unfortunately, I think the weather gods were not cooperating with us that day, but Michelle is here today, and she will give that presentation on the Toronto Indigenous overdose strategy. Very pleased to have her join us, and she will provide you with great detail, I'm sure, about this very, very important initiative. Thank you, Mr. Chair.
Michelle, we may just, because there are people watching online and listening, ask you to use the microphone. Yeah. We can try to turn it, but if we can make sure you're speaking into the mic so that people who are watching online and on the live stream can hear you.
Gotcha. Okay. So my style doesn't function at City Hall. Is that what I'm hearing? That's cool.
Well, we're going to make it work.
Okay. Thank you. Here we are. I'll do my best not to move around too much. I'll use my voice, and I'll try to be really clear. This is not how I function generally, and the reason is that this is blocking energy, right? So I'm blocked from you, you're blocked from me. I just want to talk to you about the situation and the human beings who I connected with, because that's really why you're here, right? Didn't you sign on the dotted line and join or be part of, or you were asked to be part of this body because you care about human beings? So I want to read who this document was dedicated to, and I want to tell you a little bit about how we got to where we were and where we are today, okay? Where we were as in February when I was supposed to be here, and there was a snowstorm, and I was stuck in my driveway sweating while my assistant was here saying, it's fine in Toronto. It really wasn't fine at home. So this document is dedicated to the Indigenous advisor who sat quietly and shared that the love of his life had died the week prior. His grief palpable, his bravery evident, he stated, and he shared in an effort to help others live. Memories of many Indigenous people who have lived and died on the streets of Toronto, far away from the connection to their homelands, and far away from the concern of their love and their relatives permeates this document and the pages in this document. So really, the reality of the situation is I went to the people. I didn't go to the researchers. I didn't even go necessarily to those that are service providers except for one day. I spent an entire day with 24 service providers who validated everything that I heard on the streets, essentially. Most of the people who shared in these documents are very intelligent human beings who are suffering with addiction. And many of these people were homeless. Many of them were precariously housed. So I was able to utilize the support of some of the agencies in Toronto and some of the navigators who are also working with these individuals to bring them into circle, whereby they shared what it was that they felt they needed, either for themselves to live or the people that they cared about, so that they would live. Because some of the people, when I asked them, what is it that you need? What do you need so that you can continue to live? They said, I don't want to. But I said, how about the person next to you? And that got them thinking. So what it is caring human beings who care about the next person, who may not in this moment care about themselves, okay? So what I'm trying to do here is bring you back to your heart center to remember there is data, and there were numbers that were thrown around in this room, and I watched the room. I watched while people were on their phone. I watched while people were distracted. And every one of those numbers is a human being with a family attached, with a community attached. So the impact of this is rippling. And it doesn't have just to wait for somebody in our own lives for something to happen to them in order for us to do something really critical here. So let me talk about the pathway. If somebody can click me, there we go. How did I get here? I'm a facilitator. I guide strategic process with smart human beings, oftentimes leaders, and I help them to move forward through a direction of something. In this case, I happen to be the facilitator for this reclamation of well-being, an awesome strategy, health strategy that we are continuing to implement. Go. Okay, we're not doing any readers because I only have 10 minutes. Everything begins in a circle. So let me tell you about how I got the information. So I shared a little bit about bringing together folks that were Indigenous people who were using substances or had been clean for some time. The longest person who was experiencing sobriety at that point was about 2 months. So anyone who was really, really keen would lead dialogue in small circles. And I used a gentle approach, you can keep going, to build their trust amongst themselves first and to allow them to let me lead them through a process which was really going to unearth a lot of stuff. So essentially it is, what are all the reasons why it is that you are where you are? And these folks would tell me a lot of things. Historical trauma, grief, hurt, pain, institutional injustice, perhaps? Oh, look at you. All right, you just put a mic in my hand. Can I have another 10 minutes? Okay. And it's on. All right. So I would ask them then to collaborate with one another, and they would take some time to really brainstorm, I guess is the term, all of the reasons why it is that they were and are where they are today. And then I would gently say, all right, we got some concrete stuff here, but we also have some emotional stuff. And I'll tell you something that a strategy cannot do. It cannot address the emotion. You can't address someone's grief. But you can provide them with service and supports in order for them to address the grief. So let's separate the emotional stuff and let's honor it, okay? Let's make sure that we remember that this is the reason why you're here. And on the other side, let's take a look at all the concrete stuff. And these folks are so, I'm gonna stop saying folks, these individuals were so amazing. All of the recommendations that are intelligently poised here came from them. They bubble up. They know where the gaps are. They know where the services are that are needed, and they know what it is that they need, okay? So they began to then disseminate from this group of concrete actionable items some of the key recommendations that began to surface through the report. Thank you. That's not as pretty. So, how am I doing for time, Joe? All right. So I was going to tell you some stories. I thought I had a half an hour, but I'm not going to tell you those stories. But if anybody wants to hear the stories, you can find me, give me a call. But I do want to tell you about the youth. I want to tell you about the youth because I thought that these young people were so, so bright and right on just on the precipice of healing or going in a different direction. And I hope that all of those young people that I met with and those people that they are connected with will continue to try to advocate and help one another through this crisis, because that's exactly what it is. And it's a wicked problem, I would say. One of those things where you say, what do you do to address this kind of stuff, where human trauma is really at the base of why people use in the first place, right? So I was going to tell you some stories about the youth and some of the brilliant women that I met. You'll read in the back of the document, I see you have copies of just the presentation, but I do have 11 copies of the overdose strategy in hard copy if you would like it. And in the back, you'll read some of the, I suppose, the nuances of personalities that came out of the circles and the individuals that I met. And these women, I would say, very strong and very resilient women. Next one, please. And a story of why they come. This is a photograph. I facilitate and I guide, as I said, strategic process, but I also work in housing, violence against Indigenous women, and education, all for and on behalf of Indigenous people. So this is why some of them come to Toronto, because this is where they are born and brought back to. Next slide, please. Okay. In the overdose strategy, one of the things that came out was this, there's a focus on men. And there should be a focus on men, because I think oftentimes society expects that men should be they're the strong ones and they should be able to just handle this. Okay, our men are amongst some of the most vulnerable, our Indigenous men especially, having identity taken from them, their roles taken from them. They continue to see intergenerational, cyclical violence and vulnerability, and our services don't respond to them. They respond to children and they respond to women, because the women are generally the mothers of the children. And that's where we go to, because that is what society tells us we should do. But I would say, if there's anything I can say to encourage you, is to really start to look at the men and focus on some of those services for them, because you bring your men back into their families and they strengthen them and they hold their women up and they will hold those children up. Next. Who's it? All right, brother. Thank you. All right, so this was off your slide. You probably have done this before, and you actually have the latest statistics, so we can move past that slide and into the next one, back to the basics. So the report itself gets back to what I said are the basics. I was seeing a trend happening nationally with efforts to try and address the issue with some of the research and some of the medical interventions that could happen, and I think that's important to happen in tandem with the basic services. So when I asked people who are living on the streets or who are precariously housed what they needed, they said this: they need a place to shower, to wash their clothes, to get a bowl of soup, and for someone to care about them and hug them, touch them, show them that they're human. And I had shared a story, and I will share this one because I'm going to start to close this down before I get into the exciting news of the interest for this strategy nationally and what has occurred, okay? So I was about to conduct the circle for those two-spirited folks, and there was one gentleman that was there, about 27 years old, for about a half an hour earlier than anyone else had arrived. So while I was setting up, he had been sitting there, and I felt his pain. I went up to him and I said, "Do you need a hug?" And he said, "Yeah."
and I hugged him, and I held him for as long as before it wasn't creepy, you know? And he let go, and he was crying, and he said, "No one has touched me in 5 months." What? These are human beings. These are human beings who deserve love and caring. So back to the basics was, show me some love, show me some caring, show me some kindness. Each one of those numbers represents a human being who wants that. Okay. The report itself also emphasizes culture, teachings, and that's it. I want to stop at this slide because I'm probably getting pretty close, right? Where am I? How many minutes? Do I have 2? 5? Okay. So, the report. You will notice in the report that nowhere, there is nowhere where I mentioned the names of agencies or individuals other than a couple of, the Canadian Medical Association. There is a doctor that had provided us with some insights into the report. But I strategically left that out because I did not want this report to lose its relevance, both provincially and federally, okay? It needed to have some attention from those policymakers and those folks who have access to the budgets to see this as a relevant document, not only for Toronto, but that could be something that could start in other cities, okay? Going in and asking those, because we say that in the research, go and ask the people who are the ones who are end users. It's not that easy, okay? It's really, really not that easy. But we did it, and I think that it can happen in other cities. And so with this particular report, how long ago was it? Where is she? When was it that we had that call? Okay, so it's only been a couple of weeks, but we've generated interest nationally with the Public Health Agency of Canada, Indigenous Services Canada, yeah, and there was also 3 other agencies. Thunderbird Foundation, nationally, there is interest in this strategy, which means, I think, that Toronto may be an opportunity where we could see some federal intervention and supports in this city because you're the only one in the country. In fact, we've done our research, there's no other Indigenous overdose strategy in the world. So we know in Canada, and in Ontario in particular, we're seeing such drastic changes to this system. I see it as an opportunity, okay? Toronto, you have an opportunity to be the champion on behalf of Indigenous specific supports and services, because that happens to be the conversation nationally, okay? But I will tell you, when those services hit the ground, no worker is going to ask whether you're Polish or Indigenous. Let's find a way to help the people who are on the streets, the majority of whom happen to be my people. When I walk by, I see them, they're visible to me. I want to see some action on this action plan, and I think the individuals I've been working with at Toronto Public Health are incredible, and I'm really pleased to continue to support them. So I don't know how well I did with, can we go to the last slide, if I have a last slide? Okay, that's it. This is all just some, okay, let's leave it at that. All right, significance of gender, again, I'll reiterate that in British Columbia, they're also focusing on the men, okay? Do I have any more minutes? Anybody have any questions? Comments?
I think what we're going to do, and thank you, Michelle, is
You're welcome.
we're going to go, we have a deputant we're going to hear from, and then we're going to bring it back in committee for questions of yourself and Eileen, if that's all right. And with that, Miigwech, thank you. So thank you, Michelle. Members of the board will recall we had a detailed discussion in February on the Indigenous strategy and a series of deputations. There was a snowstorm that day, and unfortunately, we weren't able to hear from Michelle then, but we thought it was critical that she have the opportunity to bring forward the full presentation, so thank you. We're going to hear from deputants before bringing it in for questions of staff. I have Diana McNally from the Toronto Drop-In Network. Is Diana here? I don't see Diana. Do we have any other deputants? on this item? Is there anybody else here to depute on the overdose action plan? Okay, seeing none, we're going to move it into committee then. All right, thank you. So, sir, if I'm just going to say, if you'd like to depute, we'll have you come up. Sorry? Sorry, if you'd like to come up and take a seat, you will have 5 minutes. You do not have to use 5 minutes, but you will have 5 minutes. And when you're ready, I'm going to start the clock. And sorry, I'm going to start the clock, and you'll have 5 minutes.
Toronto's a big city, and Canada's a lovely city. It's a city of all nation, and we really need to reach out. It's a native land, and this is our oath. This is our anthem. This is something that we all took as a Canadian. I'm not sure because most of you guys are born here. I guess you haven't took the pledge to the Queen, so you don't know this. But I did and became a Canadian citizen in '97. And I respected since to honor everyone that's here. I took a leadership since I was 5. I always take care of people. It's not what makes my heart big. And this lady, I could tell she's a lovely person because she speaks about man that no one have. Every man is on the street and woman because a home has been broken, a family's been broken, divided. Now we're gonna have a championship to the world to show Canada again on the map. And this is how we're treating our people. I stand here today as a native, not as a black man or Chinese as I am, but as one nation. To hopefully this man or this lady will stand for our people that we're here today and welcome us. And this is how we were gonna repay it? How? How are we gonna show the world? This is something that we've been waiting for a moment today. Now it's time for the leaders to become a leader. There's a lot of things that people could overpower government and show them what people is, and people are the government, not corporation. It's good to take from corporation to build our own city, build our own country. This is why we let them in, not to take away from the table of the people. This is a country that we're all here, a nation, under one roof, the whole world. Why is it that we're not showing the world what we're capable of? We were peacekeepers. What happened to that? What gave away that title? We have an invincible wall against the US, just like how they build a physical wall against themselves. We don't like hate and we love love. But today is a day we're going to show the globe what a city could do to a province, to a country, to the whole world. These are my words, what I said, trying to run as a campaign individually, independently, not taking a handout from no one. And here I am today. Thank you, God, blessed Father. We're the children, we have His breath inside of us. Without it, it's only death. Let's show the world what we're capable of. Thank you guys for giving me this chance, and go Raptors, go.
Thank you.
Thank you. Any questions of the deputant? All right, seeing none, thank you.
Oh, thank you so much, bless you.
So we're now going to move it into committee, and we're going to move to questions of staff, as well as for Michelle. Do we have any members of the board with questions? Councillor Late.
Yes, thank you. I'm just curious how the national dialogue around decriminalization is proceeding. Is it?
So through the chair, as I alluded to, there are certainly many interested parties within public health. There's conversation I know happening out in the West Coast. And as I mentioned to the board as part of my presentation, we put forward a resolution at the annual general meeting of the Association of Local Public Health Agencies, and that's an Ontario-based agency. So increasingly it is entering the conversation. However, I think with respect to what's happening at the federal level, my sense is that there's conversation. We certainly have raised it, and I can assure you that I have raised it personally with the federal bureaucracy. However, I think at the political level, there is still some, I would characterize it as reticence. But it is an active part of the conversation, and we are continuing to push the point.
The another area for action that you've listed is the expansion of into underserved areas of the city. How do you see that proceeding in light of the recent provincial decision around London?
So through the chair, very interesting question that you ask. And I can tell you that along with some staff from Toronto Public Health, we had the opportunity to meet with provincial staff from the Ministry of Health and Long-Term Care not very long ago. The notion of needing more service was raised. It will continue to be raised again. And I have been also talking with academic health science partners and other healthcare partners to see what they might be able to do to support us in this regard. I'm not going to tell you that this isn't going to be an uphill battle. It is a very challenging conversation that we're having, but we're not shying away from it.
Has the province given any indication that they would be willing to entertain new sites?
Not as yet.
Okay, thank you.
I have Kate, and then I'm going to go to Sue Wong.
My understanding is that both Street Health and St. Stephen's House were denied in their reapplications, and that they were told at that time that the province would not be entertaining anymore in the City of Toronto, any more sites. But given the map that you've shown us and the need outside the core and within, have you received any information?
So through the chair, I have not received any further information around the interest that the province has in respect of expanding. We did raise it. The meeting was maybe a week ago at best, if that. So we will continue to press that point and talk about the need for health care to actually take place where the need is.
Just one further question. For the sites that were approved as new consumption and treatment sites, services, the funding has not yet flowed to the majority of these sites. It's been 72 days. Has funding for the works been interrupted in any way during this time?
So through the chair, we've continued to receive funding. And I admit I have not had the opportunity, but I'm happy to raise that issue on behalf of the other sites. When we last met with the Ministry of Health and Long-Term Care representatives, we did not talk about the funding for the other sites, but certainly at my next opportunity to discuss that with them, I'd be very happy to raise that.
Thank you.
Thank you, Kate. Sue Wong.
Inspire us to do more. So, Mr. Chair, I have several questions for the Medical Officer of Health regarding the report. So with regard to the follow-up question to Kate, is there any legal consideration that we could consider? Given the fact that there are 2 sites that's not been approved, is there any legal consideration that we should be considering asking the lawyers to look at this? Because we have a city crisis. We have vulnerable people don't have rights, and we as this board advocating for their health care. So is there any conversation with the staff, Mr. Chair, through you to the Medical Officer of Health? What legal avenue do we have to ensure these 2 sites? Because you look at the map, unless the map lies, I don't know, but what legal recourse do we have as a board to advocate for these underserved communities?
So through the chair, not being a legal expert, it's challenging for me to answer that question. That being said, we have pursued all kinds of opportunities and have opened up discussions both at the federal level and where there is some willingness at the provincial level as well. Clearly, we're in regular communication with our provincial bureaucratic partners. I continue to be in conversation with our partners at the federal level who are certainly open to considering different possibilities and different innovations, but have some limitations given the way in which the responsibilities for different issues are divided as a result of the Constitution. Health care falls very much within the provincial purview, and I have limited capacity to be able to push them into certain areas. However, despite those limitations, we continue to raise the issue.
Okay, so I know in the report, Mr. Chair, through you to the Medical Office of Health, that there's a recommendation dealing with the advocacy work, dealing with advocating to the federal government. So is there works between yourself as well as the chair, since the chair's been so vocal about our recent budget crisis, to meet with all MP in the city of Toronto? Because now that we are into the middle, we're starting with the federal election cycle, is there a plan, Mr. Chair, and the Medical Office of Health to meet and advocate for the position of all four public recognized parties to deal with this particular position that we're taking as the Board of Health?
So through the chair, we certainly have been pushing as much as possible with respect to anyone who will listen, and that includes the federal MPs who represent Toronto ridings. But I will tell you that the vast majority of our conversation, because we feel that that's where we can most advance the conversation, happens in concert with our federal bureaucratic partners, both at Health Canada and at Public Health Agency of Canada. I'll leave it to you, Mr. Chair. I'm not sure. I think there were some questions that were specifically with respect to what we might do here as a board and what might happen from the chair's seat.
Okay, that's it. Thank you.
Any other questions of staff? Second round for Kate, but just happy to go back to Kate. Anybody else? Okay. Kate?
Michelle, I have some questions for you. I'm interested to hear, given the political context that we're in, what progress you see happening or would like to see happening on an Indigenous-led consumption and treatment service. That's recommendation 4.1.
Great. Is this cool? Yeah, okay. I think your hope with that particular one is going to be with federal intervention and supports. Testing an Indigenous-specific consumption site here in Toronto. I know there's, Vancouver's way ahead of us on this conversation, and they just are, right? It's difficult because we have these, you have to have the meetings first and get the cash, but I believe that we can push for some more interest and support federally with that particular one. I think provincially, I don't know where the conversation rests, and I appreciate what it is that you're asking, because it is a crisis. It's happening, though, everywhere, right? What Toronto has is you have a foundation of support services and Indigenous-specific support services and a population. And that's what the federal government will be looking for. And I say this could be a test site in terms of what can happen if you do intensive on-the-ground interventions and supports. At this point, utilizing federal supports, there's at least 4 specific bodies interested in this strategy, how they tie in, and we've been given access to individuals who have some pots of money. So let's talk about that perhaps with them. And I see that could be a really, yeah.
And do you see a role for Toronto Public Health or this board in helping to support what the recommendation 5.2 around specific accountabilities for Indigenous cultural safety? Do you see a role for this board and Toronto Public Health in supporting what those accountabilities might be or might look like?
Absolutely. So this board is the creator of, you birthed the Toronto Urban Health Fund. And the Toronto Urban Health Fund now will have, I don't know whether it's come to you yet, but an Indigenous-specific stream. I think in any funding that you provide to Indigenous or non-Indigenous agencies, there should be accountability mechanisms. But let me say that for Indigenous-specific services, they are in competition with their non-Indigenous service providers who provide service to Indigenous people, okay? And that is because that's necessary and that's where the people are going, okay? But from an accountability perspective, how many of these agencies build in the term Indigenous or have Indigenous-specific in their reporting, yes. But in their strategic plans, was this an afterthought because funding came down, or is this something that happens as part of your planning processes as you move forward? Are you looking to target supports to Indigenous people? And how many agencies are you connecting with that are Indigenous specific? That means the human beings that you're talking to are Indigenous and the folks you're partnering with are Indigenous. So accountability comes with, let me see how you planned for this, let me see your reports, and really focusing on whether or not they are looking to recruit Indigenous staff, even though their mandate may not be specifically staff. So it happens on the front end, middle and tail end of this. We often just look at the tail end when we're looking at reporting and accountability. But accountability begins right at the very beginning of a conversation. Yeah, you're welcome.
Thank you.
Anyone else?
Any other questions from members of the board? Okay, we're going
Thank you, Kate, for asking me a question and giving me a chance to use this mic one last time. Thank you, everyone.
Thank you, Michelle. Move it in. Speakers. Anybody to speak? Trustee Donald.
Thanks. I just wanted to share that the TDSB last year passed a motion to have naloxone kits in all of our secondary schools and to train staff in those schools to use them. We've got 50 schools now with the kits and staff trained, and we're working on getting more of them. I think we have 110 secondary schools. And I also want to share that youth and students are really engaged and really fully understand the crisis that this is, and they've been contacting their trustees to ask for more action too and within the schools. So it's important to note that everyone's in this together in our city. That's all. Thanks.
Thank you, Trustee Donaldson. Anybody else to speak? Okay, I would like to, I'll say a few words. First of all, I will move the staff recommendations that are in front of us. I would like to thank our staff in Toronto Public Health and the Toronto Drug Strategy Secretariat, as well as the frontline workers within Toronto Public Health and in a number of the community agencies. And I think the work that they do not only saves lives, but it does so in a manner that shows dignity and as Michelle Sue spoke about, also demonstrates kindness and love to the clients who use those services. It has been 2 years since we endorsed the Overdose Action Plan in March of 2017 here at this board. And we've now seen overdose deaths in this province become the leading cause of death of young people. We talk about the overdose crisis monthly here at the board, and I'm sure certainly like many of you, but especially people on the front lines, I find myself rather tired of seeing more and more preventable deaths take place, increasingly tired of the stigma that remains associated with drug use, and also tired of going to memorials. I was at a memorial last night with about 150 frontline healthcare providers for a man, Leon Pops Allward, who deputed at this board many times. In fact, in March of 2017, when we endorsed the Overdose Action Plan, he deputed and spoke about the need for services because he was worried for his life and his son's. And he spent 2 years working, first to set up what was then the unsanctioned Moss Park overdose prevention site, became sanctioned, and worked at Parkdale Queen West at one of our supported overdose prevention sites. He saved lives every single day, and even with all his knowledge and all his expertise, he was not immune from passing away from a preventable death. And so I'm tired of those memorials. I'm deeply proud that in this city we have in part stemmed the tide of this epidemic, but it has not abated. And when you hear that we've had in 19 months 50,000 client visits to the works and 845 overdoses reversed, we can and should take deep pride in the work of city staff, in their role in confronting this epidemic. But we know that it is not abated. And so the recommendations in front of us for all levels of government are critical to scale up the work and to continue to scale up work on treatment, on prevention, and on harm reduction. And I often remind myself that if this was anything other than drugs and illicit substances, governments would have solved this crisis a long time ago. And so when you hear from the medical officer of health that for the first time in 4 decades, that life expectancy in Canada has gone down because of the overdose crisis, I'd ask us all to let that sink in and to grieve, and then if you're like me, to get really angry and to demand better. And so our resolve will continue at this board and in the city to demand better and to provide more services. And one day this epidemic will stop, but far too many people are going to die before it does. And with that, I would ask for a recorded vote on the staff recommendations for the Overdose Action Plan, and I would like to inform the board that this Overdose Action Plan is going to City Council, where we will be seeking a recorded vote as well.
Angela Johnson, Councillor Cynthia Lai, Councillor Mike Layton, Councillor Joe Cressy, Trustee Ida Lepretti, Councillor Jennifer McKelvey, Kate Mulligan, Councillor Gord Perks, Peter Wong, and Sue Wong.
That is unanimous. Thank you. We're now going to move towards our next item on the agenda, which is item 7.3, Fetal Alcohol Spectrum Disorder, Activities to Address Key Priorities. We have a deputant listed, and so I would like to invite Sharon Richards from the Toronto Fetal Alcohol Spectrum Disorder Network to come forward. Sharon, it's always a pleasure to see you. I'm sorry I'm no longer your counselor. That claim now belongs to Councillor Layton. You have up to 5 minutes, and there is a clock on my right, which I'll begin whenever you're ready.
All right, I'm ready.
Okay.
So good morning, everyone. And the previous conversation I would like to suggest is a wonderful segue into a conversation about fetal alcohol spectrum disorder, which is more commonly known as FASD, because I couldn't help but ask myself how many of the people we're talking about who are struggling with addictions are also struggling with FASD. So that's it. I would like to begin my presentation by reading a note recently shared with me by the mother of a 14-year-old son diagnosed with FASD. Some of you know me, some of you think you know me, some may not care to know me, but regardless, let me tell you who I am. I am a wife, a very proud mom of 2 amazing young men who chose me to be their parent, a pet owner and a business owner. Pretty standard stuff. I am a fierce advocate, a volunteer, an educator, an advisor, a nurse, a doctor, a referee. I am the one who stood between conflict in order to have the innocent not hurt. I am the one who learned the mental health and judicial system quickly and how unfair and underfunded it truly is. But what most of you don't know, I am a parent of a young man with FASD. I may not like him some days, but I love him to bits, regardless of the troubles, and would not have done life differently. Days are hard and at times seem never ending. People don't understand, and I am looked at as a bad parent, always judged, but I know the truth, and that's all that matters. I have lived a lifetime of sadness in the last few years, but get great joy out of what most would seem trivial. When my son remembers what day of the week it is, I am so proud. Or when the school didn't call, it was reason to celebrate. I have been hit, punched, bit, kicked, battered, and bruised, and called every name imaginable in both public and private, and always having to remember that every day is a new day. But life is good. I have the boys, my husband, my animals, a roof over my head. I don't want pity or sad emojis. All I want from you is for you to make just one person aware, please do not drink while pregnant, or if you are thinking of getting pregnant. FASD is totally preventable. And that was written by Lori M. So our network, the Toronto FASD Network, has submitted written documents telling you who we are, what we do, and what we recommend the city can do to better serve the city's children, youth, and adults affected by FASD and those who care for them. We urge you to not only read these documents, but to really give strong consideration to implementing the recommendations in them. So in the few minutes I have remaining, which is not many, I would like to leave you with these key messages related to FASD. First of all, it is a brain-based neurodevelopmental disability resulting from prenatal exposure for a fetus to alcohol, and it impacts physical, behavioral, emotional, social, and cognitive functioning. It is the leading cause of developmental disabilities in North America, and it is now believed to be at least as, if not more common than autism. It is referred to as an invisible disability because while a small percentage of those affected display facial features associated with FASD, most do not and look no different than those not affected by the disability. People affected can be of average to above average intelligence, so they are assumed to be able to behave, perform, and achieve like everyone else, whereas in reality they simply cannot because of their disability. Every day they experience failure when they are expected to live up to expectations that are unrealistic and do not take into account their damaged brains. FASD is preventable, but it is not curable, so those affected will require lifelong support. And because the disability impacts one's adaptive and executive functioning, those affected in all likelihood will not manage to live independently, but they can successfully, with support, live interdependently. Dysmaturity is a hallmark of FASD. The rule of thumb is that those affected function at a level about half of their chronological age. That has significant implications for service. And when service systems fail to understand and accommodate the disability, it is harmful to those living with FASD and leads to poor service outcomes. Those affected are beginning to demand to be heard and involved in making decisions about themselves. The campaign, Nothing About Us Without Us, reflects this demand. The real FASD experts among us are those living with the disability and those caring for them. For many years, they have pretty much had to go it alone in learning about the disability, experimenting with what works and what doesn't, and creating strategies for how the disability can best be managed. We would be wise to listen to them, to what they've learned, so they can teach us how to better serve and support them. And the good news is that when children, youth, and adults affected by FASD have their disability recognized, can access appropriate assessment and diagnostic services, can access throughout their lifetime services, resources, and supports that understand and accommodate their disability, are appropriately supported to live interdependently rather than dependently, and have their strengths identified and nurtured, they will experience positive service outcomes and lead full and productive lives.
I'm just going to ask you to wrap in one sentence as I gave you an extra minute.
I just want to thank you, Joe, for bringing this motion. I probably should formally say Councillor Cressy.
Until I'm 40, it's Joe.
Okay, Joe, bringing the motion forward, and I want to say bravo to all of you on the Toronto Board of Health. I don't know if you have any appreciation for how important having this conversation today at the City of Toronto as a public discussion is for those affected and for those who care for them, because they feel like they're alone and not heard. So bravo to you all, and go Raptors, go.
Thank you, Sharon. Questions for Sharon? So I have a couple. So can you tell us a little bit about the FASD coordinating committee or network here in the city and who it comprises?
Yep. It was created or established in about 2005. It's had its ups and downs, but at the current moment, there are about 43 members of the network. They are parents and caregivers. They are service providers. They are a representative from the Ministry of Children, Community and Social Services, and then there are some community volunteers like myself.
Sorry, go ahead.
In one of the documents that I have passed on to Julie is a background on who it is and what we've accomplished, and we've done a lot over the course of the year. So we're very active now. Our 4 priorities, just established in April, will be prevention and awareness, supportive housing, big need for people with FASD, intervention and support, which will cover case management. We want to look at a coaching program for Toronto, which has been very successful out west. And what's the fourth one? I never remember. I think it's education and research, maybe. Advocacy. Advocacy. How could I forget advocacy? It's the fourth one.
So some of those, supportive housing, prevention, access to services, some of the priorities you mentioned.
Yep.
You know, across different jurisdictions. So can you give me a sense on FASD specifically about what networks may exist or partnerships working across levels of government specifically on FASD? Because we're looking here at the City of Toronto,
Yep.
where our part to play is.
You got it.
So what are the current forms of partnership or relationships with other levels of government, and are you aware of any with the city currently?
Well, we have public health, have been a member of the network from the get-go, way back in 2005, and continue to be a very active member and have been very supportive and play a very active role, actually, in the activities around FASD Awareness Month, which is September, and particularly September 9th. The representation on the network is fairly broad, so there's a number of sectors represented on the network who also have their own network, so I'm not sure how much the tentacles reach out there. We've attended the consultation. I'm not probably going to get the names correctly here, but the consultation that the city, your housing services held, looking at developing their new housing plan. So we attended that in, I think it was May or April, I can't remember. We've had we've had a conversation with someone from your shelter system. So we're making connections. We're always connected to the provincial FASD body, and so those are the connections that we have with the city.
Okay, no, that's very helpful. Those are my questions. Any other questions? Trustee Donaldson.
Thank you so much for your presentation. I'm interested in learning a little bit more, if you can tell us about how diagnosis happens and at what point in what age and stage it's best to happen, and if you are aware or have experienced any trends in the barriers that exist to those diagnoses.
All right, so let me try to remember all those questions. First, I just want to say an early diagnosis with an appropriate intervention plan is absolutely critical and crucial in supporting and helping people affected by FASD, because it will prevent some of the later disabilities that are associated with FASD. As I understand it, it's usually better to wait until a child is about 4 years old or older. So entry into school age is a good time to think about doing a diagnosis. Diagnostic services here in Toronto have been cut in half. We've lost Mother Risk, and we've lost the service at St. Mike's Hospital, or at least I think we do have. We have one service for the non-Indigenous population, which is Surrey Place, and we have someone from Surrey Place here. And they do a diagnosis, have a diagnostic service both for children and youth, as well as for adults, okay? And then Anishinaabe Health will provide diagnostic services for Indigenous community. And a diagnosis is difficult to obtain. And it's difficult to obtain because you need a confirmation that mom drank during pregnancy. That is very difficult information to get. First of all, we have all the stigma that's attached to women drinking, period, let alone drinking when they're pregnant. So women are very reluctant, for very good reasons, to come forward and acknowledge that they drank. Secondly, our service providers who are seeing women at the intake level and in our service agencies are not asking the right questions. So everybody needs to be trained about FASD and about how you ask those questions in a way that you can get the information you need. So we've had some success if there's a family member or someone who knew the mom who can say, yes, mom struggled with alcohol addiction and drank during the pregnancy. And we've had some diagnostic services, well, now some accept that. but we just don't, the services aren't there, to be honest with you. Surrey Place, for a long time, because it's their mandate, they serve people with developmental delays. There was an IQ requirement for children and youth, but they've just recently done away with that, which is a wonderful piece of information. So now any child can be referred for diagnosis. So if you had an IQ of 70 or more, you weren't eligible for their service. They've done away with that. But that was their mandate. That was their agency was set up to serve that population. They are also doing wonderful work in providing adult diagnosis. Did I get all your questions, or did I miss one? Okay. But it's really important. So training for everybody in all of your services here in the city. And Joe, just so you know, I've also submitted the report we wrote for the Board of Health to Julie. So I don't know if you've got it, but hopefully you'll get it at some point.
It will be circulated, yeah.
Yeah, okay. So there's a number of recommendations in, no, that's not it. Oh, maybe it is. But diagnosis, so that's the story on diagnosis. So we really, and my understanding is that in the previous provincial government, they actually came out with the first FASD strategy we had here in Ontario. There's some things that could be added to it, but nonetheless, we finally hit a strategy. And they, one of the things they were looking at was diagnosis. But I don't know under the current government where that is and where they're going to go with it. Okay?
And just so members of the board know, you'll see from the Toronto Fetal Alcohol Spectrum Disorder Coordinating Network a communication that includes a report that is being written for our board. You have that package. Any other questions for Sharon? Okay, seeing none, we're going to bring this into committee. Thank you.
Thank you.
Are there any other members of the public who wish to depute on this item? Yeah, please, you can. So you can take a seat. You'll have 5 minutes, and there's a clock just up to my right, your left, when you're ready.
Thank you. My name's Irene Madero. I'm a parent of a child with FASD. To your question about DSO and who they serviced, the IQ quotient meant, and their mandate was the bottom 5% of the population with intellectual disability. They're currently servicing how many? 24,000. That represents 5%. My son was diagnosed 4 months before his 18th birthday. We have struggled and struggled to find services for him. He's been revolving between jail and the streets and shelters where he's been abused, left on the street for dead after he was assaulted by 7 people through the shelter system. He's currently living in a developmentally delayed retirement residence. He's currently 21. He is living with retired age people because there's no supportive housing for him. He's left on his own. We have a reconnect worker who's a housing worker who's attempting to keep him in. But he's never had appropriate services. We need to look at these people. And what happened, we tried to support him at home about 2 years ago because there was no housing and he lost his housing and he was living, and we didn't want him living on the street. Long story short, I almost lost my daughter because of it. My husband and I have been struggling because we can't work looking after him and our nerves are at end. You need to know what people are experiencing. There was a gentleman from Ottawa who came in to do a survey of people that I was invited to, and at that survey, there was a woman there who said I'd adopted, and we are also adopted of two children from Siberia. One of them my son has fetal alcohol spectrum disorder and my daughter does not. And she said, I've lost my friends. I've lost my job. I'm about to lose my housing. I've lost my husband. I'm alone looking after this child that I can't let go because they deserve something. You've got to do something. This is ridiculous. Canada is a developed country. We're only as strong as our weak, and we're just conveniently ignoring them. I see ads for these opioid overdoses and things, and I'm thinking, how many of them are FASD? Why can't we get ads out there to stop people from, and take a second look at drinking when they're pregnant? One of the Western provinces, when you go into the bar, they have condom dispensers, they have tampon dispensers, and they have pregnancy tests. We are so far behind. Honest to God, you do not want the life of someone with FASD, and you just have no idea the cost that it's taking on the society. We are no longer paying into the coffers. Our family is drawing on the coffers now. You have no idea how expensive this is because you're not looking at the overall costs. It's so easy to prevent FASD because most of the people who are drinking are not addicts. They're not alcoholics. They're next door, they're down the street, they're in the next block. FASD is not born of addiction. FASD is born of ignorance and unawareness. We need to get the message out. The billions of dollars in taxes that we collect from LCBO, where are they going? Why isn't some of it put back to help these people? It's ridiculous. You have to stand up and do something. You can't allow these people to live this way. And every time I see my son or pick him up off the street or whatever, he says, Mom, I love you. And I can't be with him. And I'm not alone. 5% of our population or more has FASD, and we're ignoring it. 20 years, FASD World's been trying to draw attention to this thing, and nothing's happening. Network, 12 years? Yep. 12 years, and nothing. I'm in touch with Ford's office, and they come back and say, well, we've only been in a year. And I said, but we've been working on this for 20 years. That means that you had it in your bailiwick 3 years before the Liberals took over. I met with Mr. Ford personally. He was unaware that it was FASD Day. He was unaware that it was September as FASD month. I've had conversations with people from Ford's office, one for an hour, and when I tried to reach her again, the number was disconnected. So I went to my MPP yet again, who I've been working with for over 4 years, and got another number to phone to find out it was disconnected.
And I don't mean to interrupt. I'm just going to ask you to wrap up in a sentence.
Okay, so I've talked with the deputy mayor about this situation, and nothing seems to be happening, and they actually voted against shelters. The only reason I hope that they voted against increasing the shelters, temporary shelters, is because they're hoping that somebody's going to make permanent ones. Please, please, please. You have no idea the ripple effect of this nasty thing that can be prevented. We need awareness.
Thank you.
Thank you.
Thank you. Are there any questions for, sorry, sir, in the back, I'd ask you to not interject. Are there any questions for the deputant? Okay, seeing none, thank you very much. And are there any other members of the public who wish to speak? Okay, we're going to move this into committee. Questions of staff. Sue Wong.
Thank you very much, Mr. Chair. So this is a very interesting time, Mr. Chair. I still remember the FASD item on this board when Councillor Kay Gardner was the councillor here, and this was the same issue. So now we're 20 years into the FASD, we're still talking about it. I think more pressing, Mr. Chair, I want to say thank you to the staff for this update dealing with the FASD report. But I think there's more questions that need to be asked dealing with the whole issue. We just heard the two deputies dealing with the education, and especially with the school boards. I can't stress enough. So through you, Mr. Chair, can I get an answer dealing with the prevention and the policy piece as it relates to the TDSB, the Toronto Catholic District School Board? Because we heard consistently there's enough data that prevention is an ounce of prevention, but more importantly, what is the staff doing in support their education and awareness to support the education community? Because I don't see it in the report. Particularly the fact that I remember when I was at the province, the select committee on adult with disability has a huge section dealing with the education and awareness. So through you, Mr. Chair, can the Medical Officer of Health share with us what efforts has been done with the two public school board, but I think there's 4 school board we have, dealing with this issue of FASD? That's the first question.
So through the chair, thank you for the question. At a very high level, we have a Healthy Schools and Substance Misuse program as one of our components of public health programming. And clearly alcohol and discussion is one of the substances that will be actively discussed as part of the education program that we have. I would also suggest to you that we are actively engaged on alcohol policy writ large, beyond education at the school. I think there is a significant amount of work that should be done in the prevention realm that actually has to do with policy, and you'll be hearing as a board about this at an upcoming board meeting.
Okay, thank you. So my second question, Mr. Chair, through you to the Medical Officer of Health, with respect to the whole issue of our strategy, is there conversation, given that we just passed the provincial budget, there will be proliferation of the sale of alcohol, and what is the staff is about to undertake? I know the province doesn't like us to do any advocacy work. However, we got to do advocacy work if we're going to get to the bottom of this issue. So what measures is the staff is going to be considering in terms of awareness? I think it's more than just a poster in the liquor store or in the bars. What conversation are we having in planning, piggybacking existing campaign that we will be considering in the fall?
So through the chair, I would suggest to you that there are certainly some awareness activities that we will participate in, but I would put to you and to the rest of the board that in fact, I think the policy levers are the most significant ones we have at our disposal right now. So with respect to the province is the key decision maker in respect of alcohol policy, right? As is, that's the case here in Ontario, and you'll see that throughout other jurisdictions. We know that our current provincial government is making a lot of decisions in respect of alcohol policy. I can tell you that I personally, as a member of the Council of Medical Officers of Health of this province, actually had the opportunity to speak with the Ministry of Finance representatives specifically on this subject and gave them some very clear advice on the public health concerns and issues that we saw with the current direction that is being taken by the province on alcohol. That was the opening salvo. There is still more conversation that we're having. We're actively pursuing on the policy front. And as I mentioned in the answer to the earlier question, we will be bringing forward a report to this board on the activities that we foresee as key in ensuring that we mitigate the public health risks associated with alcohol. Education and awareness is one component of that. I think there are other activities that I'm sure you'll find very interesting that we'll be putting forward as well.
Thank you.
Thank you. Other questions of staff? Yeah, Councillor McKelvey.
Thank you, Mr. Chair. My question is about other programs that are also connected with FASD programs. So things like mother risk, I know were just cut. I was wondering if you could kind of give an overview of what sorts of cuts have been happening in this area right now, and is there anything we need to be doing? Because I know mother risk, I think, also did some FASD work, and that's now non-existent.
So through the chair, that's a program that's actually outside of our scope. It's funded as part of the hospital network, as I understand it. I'm going to turn over to our staff to see if they have specific information on that. If we don't have information today, happy to bring that back to the board.
So
Through the chair, as the deputant mentioned, there were previous programs, St. Mike's and Mother Risk, that were cut. There are 2, as you note in the report, that are available. They're very pressed for the volume that they deal with. And those are programs that are available for screening or diagnosis. And the follow-up programs, again, as the deputant mentioned, are a range of things all the way from social housing to various kinds of coping mechanism programs. Those aren't our purview, but what we have done working over the years with this particular advocacy group is help them access the city's huge plans around housing that have now grown citywide and are looking very deeply at the supportive programming that's offered as well as the location and the bricks and mortar. So there's a lot of hope there because the city's taken a real citywide approach to looking at this with SDF&A, with shelter support and housing, and looking at it across the continuum. So I think it's been a long, hard struggle. We certainly appreciate that and have been with this group, but there's some really positive hope in the work that's going on the 10-year housing and homelessness plan that's going to come forward to council in the fall, as well as with the overall housing strategy. So we have been working hard to connect this group to those folks who are actually able to have direct within their mandate both the programming and the housing issues.
So would it be possible, as you continue to report back on us, to look at what the gaps are now that are going to happen now that these cuts have been made at the provincial level, but more specifically how they'll impact us here?
Certainly, we can report back on that.
Thank you, Councillor. Any other questions for staff? Okay, we're going to move it in for remarks. Anybody to speak? I'm happy to speak. Let me begin, first of all, by I will move the staff recommendations, and I also have an amendment. And there's a third. It had been advance circulated, but there's a third, which is the third to ensure that this report is forwarded to all the school boards. I didn't list them individually because we wanted to include the French and Catholic and English and others. One piece specifically related to Toronto Public Health on prevention and awareness, and the second on supportive housing. I think, let me first of all thank the deputants for coming in, for not only speaking to the work of the FASD network, but also speaking to lived experience. It has been said that FASD is the leading cause of developmental disabilities in North America, but in many ways it is an invisible disability. And so while we may estimate that within Toronto there are somewhere between 50 and 90,000 people living with FASD, it could be much higher than that. And one of the challenges with this invisible disability is that it is interjurisdictional in its response and oversight across all levels of government, including school boards. And that, I think, has allowed this invisible disability to not receive the prominence and the focus it requires. And part of when I had brought forward the request to have staff report on FASD in the summer, and today's the report, is that I certainly recognize that we have a stronger role to play in our city, whether it's on prevention, access to services, housing, be it in shelters or supportive housing, to give prominence to responses necessary to FASD, but also to use this as a moment to push, prod, and raise awareness for other levels of government. And the staff recommendations in here are to bring this to the departments that deal with service delivery, so whether that's Social Development and Finance Administration or Shelter Support and Housing Administration. On the supportive housing front, I'm glad to hear that the network, the FASD network, is already in touch with our staff as they develop our new housing opportunities plan, and we want to keep that front and center. And so I would just close by saying that this is an exceptionally difficult disability to diagnose, which makes it all the more harder to serve. And the challenges are interconnected to a number of other challenges in the city, whether it's, as we've heard, related to the overdose crisis, to the status within our shelters and the crowding, or in the absence of supportive and transitional housing for people with FASD. And so there is much more to be done on this. I'm glad that staff, and I want to thank staff for bringing this forward here, but this is going to be a conversation that will carry on as we look to scale up our work and to give prominence where it deserves. And with that, I'll conclude my remarks. So is there anybody else to speak on this item? Thank you. Sue Wong.
Earlier, accessing to service is a challenge, but we want to make sure not just the housing piece that we're concerned about to support this vulnerable community, but also Parks and Recreation staff that aware of these challenges because they have children with FASDs in those programs, how to support those staff to ensure that they don't get discriminated or being asked to put aside. So we need to make sure that our frontline staff across all departments is aware of these young people or seniors or adults with this particular diagnosis are being properly supported, but more importantly, to make sure the future reporting from the staff on this particular item that tells us what can we do more, because this issue is not going to go away. In fact, it is a point of more challenge than actually the autism file because there's a huge awareness about autism. There's very few discussion about FASD. So future reporting, Mr. Chair, about this particular issue about module, who has completed this program, but more important, making sure frontline staff are supported so that they can forward to continue to support this community.
Thank you. Any other speakers? Seeing none, can we take the amendments and the staff recommendations as a package? All right, I'll ask for all those in favor of adopting the amendments and staff recommendations as a package. Any opposed? Seeing none, that carries unanimously. Thank you.
Yes.
Our final item on the agenda is item 7.9. This is the Board of Health's meeting procedures. We had deferred this once before. There was a request from many members of the board who are new to this board to ensure that we actually spend just a little bit of time to run through the procedures of our meetings to ensure that members of the board, including councillors, because I often get confused myself, are up to speed on how this should work. And so we're going to have a presentation on that. And this will be our final item. Oh, wonderful. So I will turn it over to staff from the clerk's office.
Thank you. Good morning, everyone. My name is Jennifer Forks. I'm the manager of the Committees and Boards team in the City Clerk's office in the Secretariat unit. I'd like to thank the Chair and the Medical Officer of Health for the invitation to come and speak to you this morning about the Board's meeting procedures. The Board's meeting procedures were adopted back in January of 2019, and since that time, a few new members have been appointed to the Board. However, the Board has also met about 4 times since that time, and so I expect my presentation will be more of a recap and a confirmation that you are following the Board's meeting procedures rather than any new information. So the Board's procedures can be found in Bylaw 2, 2019. They are linked both in the description of the Board in our City of Toronto TMMIS system and can be also found online. As you've experienced through this meeting and many other meetings, there is a sort of regular rhythm to the way that boards consider matters as part of their order of business. So I won't go over that since I watched it happen this morning and it looked like it went very smoothly. As you've experienced on most of the items in today's debate, they also follow a rather predictable process where there'll be a presentation, then hearing from the public. The board members can ask questions of the members of the public who speak. They can also ask questions of your officials. Then they can make their own speeches, place any motions, and then voting occurs at the end. The chair or vice chair has a variety of responsibilities to ensure that the meeting procedures are followed, as well as making some rulings when matters arise. Yourselves as members of the board also have some roles and expected conduct, which again, I'm sure are very familiar to you all. And Julie Lavertu, who is from the City Clerk's office, has been appointed board secretary, and our role as the secretary of the board is to provide you notices of meetings, agendas, and we also record the meeting procedures. We issue your minutes, and one of the key services that we do provide is that we assist members with the wording and writing of their motions. This service is offered on a confidential basis to all members of the board. And we also provide procedural advice to the chair, but obviously the chair or the vice chair will issue any rulings if a matter comes up during a meeting. I just want to call your attention to a few things that might be new and different for those who have served on other boards. One is how matters become placed on the board's agenda. So matters can be put on the agenda by members of the board, City Council or one of its committees, the medical officer of health, or as the other city officials. We also put any written communications about agenda items into your agenda packages, as well as if you've experienced today, we circulate them in the room once they're submitted to us. One of the key things is that the agenda deadline to submit new business items to the board secretary is 10 business days before the meeting. So all board members are allowed to submit items to the board's agendas. We just ask that we receive them from you at least 10 business days before the meeting. The agendas are provided to the members and they are also made public 5 business days before a meeting, and you will receive confidential materials under separate cover from your agenda. Another thing that may be new to some of you is the Municipal Conflict of Interest Act. So at the top of the meeting, the chair asks for members to declare interests, but obviously they can be declared at any time if something arises during the course of a meeting. What is a bit new recently is changes to the Act now require that members must disclose their interests both verbally and in writing, and then avoid taking part in the discussion. And it's this piece that is in writing that is new to the Municipal Conflict of Interest Act. So Julie and her team would have provided you with samples of a form that you can fill out to be able to submit your declaration of interest in writing, and we recommend that you prepare that in advance of the meeting so that when you make your verbal declaration, it matches the written declaration. However, sometimes things can't be avoided, they come up very quickly, and so our teams will remind you if you are only making a verbal declaration that you also need to submit that form in writing. We also maintain a public registry online of all those written declarations, which is provided as an open data source and available, again, online. Another thing that may be a bit different from some of the other bodies you may have served on is our requirements for open meetings. So all meetings are open to the public. All meetings must begin and end in public. However, the board is able to close a meeting to the public if the subject of debate falls under one of the exceptions to the open meeting rules. And in order to go into closed session, the board needs to adopt a motion to close its meeting, and it must provide its reason as part of that motion. And here, just included in the presentation and in your meeting procedures are the list of exceptions that allow the board to close its meetings to the public. Again, as you've experienced today and at your other meetings, members of the public are entitled to come and speak to the board. They are asked to register with us in advance, but obviously the chair may invite to make sure that everyone who wants an opportunity to speak to the board on a matter has the opportunity. So the meeting procedures do allow for persons to speak even if they hadn't registered in advance. You've experienced being able to ask questions of your officials, as well as making speeches and placing motions. I'll skip through some of the mechanics. The last thing that might be different from some of the other bodies you've served on is the rules around voting. So if you are present, you must vote, unless you have declared an interest and therefore are recusing yourself from the vote, in which case you will be marked absent. There are no abstentions for this board. Any motions where there was an equal number of votes fail, and obviously motions that are not within the board's mandate are out of order. And as the chair has already once during this meeting, any member of the board is entitled to request that a recorded vote be taken, and in which case the way in which each of the members has voted will be noted in the minutes. That is my very quick recap of all the experiences I assume you've all had so far. However, Julie and her team are available if anyone has any further questions, and I'm also happy to answer any questions at this time.
So what I might suggest in the interest of time, thank you, first of all, sorry, thank you, is we wanted to make sure everybody collectively had that briefing. The clerk's office is available prior to meetings, after this meeting here now. If you ever have questions, if you're going into a meeting, if you're wondering how to prepare a motion, how to come forward, and of course, I'm at your disposal as well if you ever want to speak to it, but we wanted to make sure we had that opportunity. I know our intention had been to have it sooner, and we deferred it on my account. So thank you for that. And rather than do questions in a group, unless there's a dying urge. Okay, Kate has a dying urge, and then I would suggest, and so I'll turn it over to you, Kate, and then suggest for further questions, we'll take it offline after.
Thank you, Mr. Chair, and thank you, Jen. I took this question to our board secretary earlier, and she asked me to bring it to this forum.
Right.
So that's what I'm doing. My question is whether there's a bylaw related to the practice at this board that refers to trustees and councillors by their titles, but citizen members by their first names.
Good question.
In my view, that seems to create a hierarchy amongst board members that is not entirely appropriate.
So, through the chair, in response to your question, titles and honorifics are not a part of your meeting procedures, so the board would defer to the chair and its own practices on how each member is referred to, how each member is referred to.
With the concurrence of members of this board, I would be delighted to begin referring to everybody by their first name on the condition that you also refer to me by my first name. Joseph. Yes. It's Grace and my mother call me Joseph. All right, so that's excellent. No, I appreciate that. And so on a go-forward basis, and to those who are elected, too bad, y'all. From now going forward, you all will be referred to by your first name. Does that include not referring to Peter Wong as Dr. Wong, though? I really enjoy calling him Doctor.
We keep calling Dr. Wong Dr.
For the record, I'm Dr. Mulligan. Thanks.
Oh. Everybody shall go by their first name. All right. Thank you, Dr. Mulligan, for dropping the mic and setting this down. All right. So with that, we are concluded our agenda. Thank you, everybody. And a motion to receive the presentation moved by Kate. All those in favor, opposed if any, carried. Thank you.
Ashley.